ability, look at time above MIC for MSA, or even for MRSA, it's 63.3% of the time. So you've got good cytality, good pharmacokinetics, and really solid numbers. And the third thing, though, is your patient population. It is like Unison, it is like ertapenem, it is a community-acquired player. This is not for somebody in a healthcare environment, it's not for somebody from an ECF, it's not for somebody who's got wounds that have been there for months on end, unless you know you have a culture that's a sensitive organism that should be covered. You wouldn't use it in that group. And so that's one of the huge areas if you're going to use ceftaroline. You got to have good patient selection. But you're right. If somebody's seen one time in the ER, given an IV, then put on an oral and sent home, vancomycin would be the most logical drug to do that
Even
with.
if you gave them some Keflex with it on their first day to get some gram-negative coverage.
Well, I think more strep coverage. Well, Vanco would cover strep.
Yeah. But it just seems, and I don't know what our new ER group is like. We used a lot of one-time Vanco, or a lot of one-time Teflaro doses out of the ER, and I just wondered how that was really benefiting the patient, other than maybe making them feel better. I got an IV drug that should give me, that'll get me started.
Vanco has good long half-life too. I think one of the, your theoretics are that vancomycin is a large molecule, it doesn't penetrate tissue well, it's a slower killer. Ceftaroline has very good tissue penetration, is more active and has better levels, but with that being said, if you're only given one dose, I'm not sure it makes a huge difference.
Dr. Farnum, we've had certain groups of docs use quinolones for MSSA, and I've always wanted to. I know, but what can I say to them? How can I word it? I try, and I'm.
Well, here's the bigger issue: is that I've had a patient. I actually just used a fluoroquinolone for a staph luganosus that was sensitive because they wouldn't take the patient on. Patient has allergies to penicillin, cephalosporins, and no. They have allergies to penicillins and something else, I can't remember what. But anyways, this patient had basically an Enterobacter cloacae, and I had him on cefepime and a fluoroquinolone for that. And so I switched from Cipro to Levaquin to cover the staph because it was sensitive to both. And I'd prefer to use Levaquin for a staph over Cipro, even if it was sensitive. And initially I was going to use a different combination, but they wouldn't let me use, I can't remember what the drug was, it was too expensive. So the answer is I actually had to use the fluoroquinolone for the staph because the ECF wouldn't take them with the other drug. So sometimes you have to give in to that, but to send them home, there's a lot better agents, unless people have significant allergies, there's a lot better agents than the fluoroquinolone for
They
staph.
argue that it's sensitive on the panel, so why won't it work? And
there's a lot of, it's just one of those.
And
Well,
we
the
say we
bigger
just
argument-
know it doesn't work.
Well,
I don't know how
it's
to
not so
phrase
much
it.
that it doesn't work, it's that number one, we're losing susceptibility by overutilizing agents. I've got a broad spectrum agent, it's kind of like using a baseball bat instead of a fly swatter for a
They don't
fly.
get strep and atypicals.
They both will work if you get a good shot at it, but you might miss with the baseball bat.
I'd really like to see that Levaquin just stay for community acquired
Yeah,
pneumonia.
but
we're trying to use it empirically in the pulmonary, right?
Yeah.
And I agree, we teach that. We don't use it empirically in the urine. The only place we do use it sometimes otherwise, we might have Cipro use for diverticulitis just because those people that are looking to get out in 36 to 48 hours, you probably won't have a culture back. Many times you'll never have a positive culture and they want to use something orally.
They
So,
don't need Levaquin.
Bactrim or Levaquin in combination with flagyl is what they'll use, or a Cipro flagyl.
And can we actually say to them there is literature showing that even with sensitivities you don't always have success?
Well, I think the better argument is that antibiotic stewardship tells us that when we want to use the best agent in class, and a fluoroquinolone that has a lot of gram-negative baggage when you're treating a gram-positive may lead to C. diff, diarrhea, resistance factors, and I think I would be more concerned about the collateral damage issue than a failure with the fluoroquinolone per se.
Yeah, that C. diff
that's helpful.
relationship with fluoroquinolones is parallel, so.
No, I agree.
Okay, thanks.
So when I have somebody, let's go back to the IV thought though. So where do you go with this when you say, okay, they're severe enough to come in the hospital, what am I going to use? And I think that in skin, Vanco is very reasonable unless you've seen large or multiple lesions. And some of that may be surgical issues, not necessarily antibiotic issues. But when you've used drugs over the years and you've seen them not do well and you use another drug that's newer and you see it have efficacy that was above what you saw, it kind of sticks. And people ask me all the time, do I really think that in MRSA pneumonia that Vanco is superior, or Zyvox is superior to Vanco? And all I tell them is this: when I was a resident, we used to treat people with MRSA pneumonia frequently, and their pneumonia would get better, but their sputum would never clear of the MRSA. They would be colonized for life. When I started using Zyvox to treat people with MRSA pneumonia, they got better and their colonization cleared, and I didn't see them come back again and again, whether it be MRSA or a viral pneumonia and a MRSA culture. I never saw that. So from my perspective, I do think it's better, but in terms of looking at data, you know, the FDA will never let anybody advertise that because there's not two placebo-controlled trials. In fact, the people from Pfizer are not even allowed to talk about Zephyr. The study's done, they're not allowed to talk about it. They're not allowed to talk about it. So, you know, you can believe it, you don't believe it. There's certainly a lot of people out there that think that Vanco is just as good. I personally don't. I think Vanco is superior. I think there are studies that show it, smaller studies that show it too. But with that being said, it does work. But the problem is you don't get the same levels. And I think that it shows that by not having eradication. So again, what we look at today, first and foremost, is antibiotic stewardship. But the flip side of antibiotic stewardship is not cutting your own throat. I mean, if we did everything, everybody would be in deficit, because deficit is hands down better than anything else for C. diff. But yet we've got a failure in the ICU that perforated her colon that's probably going to die. All right? So, you know, hey, great drug, it still didn't work. All right? Some people are going to have negative outcomes. So you have to pick and choose who's going to be the higher risk for having a negative outcome with one of the other agents. And so we're trying to be responsible as clinicians as well. And so even the company talks about that. You're not going to use this in every patient. We know that. And so here's what we find through studies that can be the higher risk. And so people who are over age 55, people that have a white cell count greater than 15,000, individuals who are having 8 to 10 stools a day or more, people that are on dialysis, people that have received chemotherapy, people that are severely malnourished, and then being a woman. Now, I don't know why, if it's because they live longer or what, but those are the risk factors. And so there's some good studies that say, okay, in this type of a patient, you want to use it. Whereas this, you might want to try this first and then go to that if you can't. And so, you know, that's where we're at. So getting back to how did that correlate with pneumonia, you know, I think you all have your experiences over time that gives an imprint as to how well the drug works. And we know, and this is where MIC creep is, and you probably are all familiar with it, but MIC creep is where ultimately the germ is still sensitive by susceptibility, but in clinical trial and in study it does not work as well as would be predicted in vitro. So in vivo it doesn't work as well as in vitro. And so we know that there are many drugs that are like that. You know, if you get to people that are highly allergic, you know, talk about the drug Sinercid, it looks great for pneumococcus, looks great for Staph aureus, MRSA included, but in clinical trial, it really is not very good against MRSA. So, you know, I wouldn't even think of Sinercid as being my, you know, a down-the-road MRSA agent. But then you also have to remember drugs like daptomycin or cubicin have no activity in the lung. They're bound by surfactant, and so they're not good choices. So it really depends where you go. So if you talk about MIC creep, it depends on which trial you want. I've never been a big Wunderlich. Some of the stuff he presented early just didn't match what I had seen clinically, and although I don't practice everywhere, I just practice in one hospital, it's just my opinion. I just thought his data really didn't suggest that we saw failure rates as high as 25 to 30% of the time with pneumonia, with MRSA. But then you have to look at your definition of failure too. But Hyodine, it's been done by other authors and other centers, and you know, they claim that, you know, in terms of actually eradicating bacterial infection and having clinical improvements, that with MICs of 2, you're probably looking at about a 10% success rate if you look at their definition. Sequelis, his data is more in bloodstream infection, and 1.5 was about 30% success rate, and 2s had about a 10% success rate as well, 9.2%. But so we know that in deeper and invasive diseases that, you know, maybe vancomycin, because it's a larger molecule, slower killer, doesn't penetrate as well, maybe not as good in some of those areas. With that being said, there are certain patients who will do well, even with those infections. And so it comes back to a little clinical experience there, but ultimately that's where I tend to start to really separate out where I'll use a Zyvox or a Dapto versus a vancomycin.
I'm starting to see there's a push for Vanco again, because we're starting to see the MICs for Zyvox to go up.
Yeah, I saw one at 4 the other day again.
2 and 4 seems to be more common.
Well, I've seen a couple of Daptos at 2 now too, so.
And so that's, and some of the stuff I've been reading lately, they're just saying to push, keep your Vanco levels. And that's what's hard to look at the old literature with Vanco, is because they still, in all of it, they used 5 to 15 is their, and you can't use that. No one uses that.
So I was gonna have you clarify for these different types of
Yes.
infections, what your goal troughs would be for Vanco, so that we
Well,
can.
to me,
15 is
yeah, well, I
good.
think you're shooting for 15. I'm happy with anything higher than 12 and a half.
Okay, so you want us higher than 12.5, 10 to 15 isn't it anymore, it's
No.
12.5.
Well, I mean, skin,
I've
obviously.
changed it on the cards, I just haven't printed it yet.
Okay.
Because I,
Because
In
I've
the
been
skin,
writing 12.5.
I'm not worried about that in the
This is-
skin. If you can keep a level above 5 in skin, you're probably fine.
we're gonna make it all.
Okay.
But realistically, we really want to shoot for 15. I'm as happy as up to 18, as
Okay.
low as 12.1, but ideally I'd like it around 15. We do know that if you get above 18, 19, you start having, not only is it the
Yeah.
renal issues, but interestingly enough, it tends not to work as well. I can't really explain that, but maybe it's because the patients are so sick that they die, but.
Well, yeah,
that-
maybe.
Well, I mean, it's kind of like, when you look at tigacycline, they did the study on, healthcare-associated pneumonia, HAP-VAP, and it didn't cover a lot of the gram-negative resistant organisms, and even some of the people that you didn't culture anything, they didn't do well. So that got added in to their product. Even though the study was canned, that had to be added into their adverse events after, for all of the disease states. So you have to now make these comments that some people who received the drug actually did worse who didn't receive the drug, and people are like, what? Well, you have to understand, this was primarily coming from the pneumonia trial, but it's been added in. So, getting back to your question, for me, I still, if I've got a 2, I'm probably not going to use Vanco in a deep tissue. Skin, I'm not too worried about it, and that doesn't carry over to coag-negative staph either. Different bugs, even though they're staph, very different bugs, different characteristics. You can go up to 4, and you're not having a problem with there. So, and I know, really ideally what you're looking is 4 times the MIC is what you're trying to do. So, if the MIC of an organism is at 2, you can sit, around 15, 16, you're pretty good. So.
Okay.
So that's the idea behind it. I know that isn't a specific answer, but that's the problem, is that I haven't figured out how to give a specific answer to a variance of people. I mean, like I said, somebody who's young and healthy and has no underlying disease versus somebody who's on dialysis, who's albumins too, those, or you can take 2 people the same age. Those are different people. They may be the same age, but physiologically they're very different. And that's the difficulty in trying to make a decision on how you treat a patient in a hospital. When you just look at MICs and data, they don't incorporate all these different nuances and subtle things that figure in. But I mean, realistically, and you're going to see telavancin coming back very soon, I think. But it'll be interesting to see how they bring that around, because I thought there was a select group of people, like for instance, if people had a higher MIC and they had a contraindication or an allergy to Zyvox, it makes sense. It has good lung activity, and so in that type of patient, that might be the place you use it. And that's where I used it most when we had it before. But beyond that, it really doesn't offer any advantage over anything else. So, but in that select population, it may offer some advantage in the right circumstance. One could argue, well, could you use tigacycline there? Probably could. And you may have good activity there too, as a secondary agent. So it's one of those areas we'll have to think through. But realistically, when you get to IV therapy, you really have Vanco, you have Zyvox, you have daptomycin and tigacycline. I think most of these people, clindamycin, particularly in bone, unless you've got a low MIC, I just don't have the same confidence in it that I had 20 years ago. I just don't see it. I'm not sure if I would use it in lung as a single agent for MRSA. I just don't, I think it's more skin related. I think that's where I'd use it more commonly. So there aren't that many agents though. You got Sinercid, which I said I wouldn't use for the most part. I've used it once for staff because the patient had horrible reactions where their blood pressure went up by 30 points and they had horrible diarrhea with Zyvox, had a high MIC, had failed Vanco. This was a prosthetic infection. But they had removed the prosthesis and we got her through it somehow. It did work. It worked for that patient, thank goodness.
I have to say thank you because I think Ron will kill me if I pay people overtime.
Yeah. Yeah, thank you very much.
Well, hopefully it helps.